From this, we are moving out to our next session. It is setting a new course with PADCEV in locally advanced or metastatic urothelial carcinoma. And the session speaker is Dr. Alison Zhang. So she is a medical oncologist from Macquarie University, Sydney, Australia. So she has just visited India, and we are glad to have her here on our virtual platform. So, yeah, Dr. Alison, so you can take the stage.
Hi, everyone. Thank you for this opportunity to speak in India. It's lovely to, I saw some familiar faces today, early in the day, and so it's lovely to speak to such a lovely group of oncologists. I'm just going to share my screen. Just let me know if you can see it. Which one am I going to share? I think it's this one. Okay. So let me know if you can't see that. I beg your pardon, sorry.
Yeah, you are visible, ma'am. You can go ahead.
Beautiful. All right, so I'm just going to talk about the EV301 data from trial data to real world practice. These are my disclosures. So I'm going to focus on three things. I'm going to highlight the key efficacy and safety data for EV301. I believe a lot of you already know the data pretty well, so I'll try to flip through this pretty quickly. And then I'll demonstrate some real-world evidence for EV use in the post-platinum setting and use case examples to highlight the management of common EV side effects. I believe EVs just come to India quite recently, so hopefully my insights will help you particularly with those side effect management of EV. So the standard paradigm of first-line metastatic urothelial cancer prior to EV pembrolizumab becoming, I guess, the international standard of care is to give platinum-based chemotherapy for 4 to 6 cycles, followed by PD-1, PD-L1 blockade, either as maintenance treatment or second-line treatment with pembrolizumab. So beyond platinum chemotherapy and immunotherapy, it's really an area of unmet need. If you have a response to platinum-based chemotherapy and you go on to maintenance avelumab, your median life expectancy is about 21 months. And if you have progressive disease on platinum-based chemotherapy, your median overall survival is only about 10 months. So certainly there was a lot of room for improvement based on those numbers. So enfortumab vedotin is an antibody drug conjugate, as you would all know. The antibody targets Nectin-4. There's a MMAE payload, and there's a cleavable, which is all joined by a cleavable linker. So the EV301 study recruited patients with metastatic urothelial cancer who had received prior platinum-based chemotherapy as well as a checkpoint inhibitor, and patients were randomized 1:1 to either enfortumab vedotin 1.25 milligrams per kilogram at a schedule of day 1, 8, and 15 in a 28-day cycle, or docetaxel, vinflunine, or paclitaxel, which would have been the standard at that point. And it was physician's choice of which chemotherapy agent you could use. I'm not sure if vinflunine is something that's available in India. Do you guys use vinflunine in India at all? No? I can't see anyone's faces, so no?
Can you please repeat, ma'am?
I said, do you guys have vinflunine chemotherapy in India?
No, vinflunine is not available. Not
available. Okay. So it wasn't available in Australia, but when we did the EV301 clinical trials, we certainly used vinflunine as the standard of care arm, just so we could access another line of treatment. Now I've just lost my screen share, so I'm just going to stop sharing and then share again. So sorry about this. All right. The primary endpoint for the EV301 study was overall survival with secondary endpoints of progression-free survival, overall response rate, and disease control, as well as safety and tolerability. This is the patient demographic from the EV301 study. The two arms were pretty even with respect to, as you would expect with a randomized controlled trial. But what I wanted to really highlight was that 20% of patients were over the age of 75. About 65% of patients had previous tobacco use, and 20% of patients had a history of diabetes. These were really quite high risk group of patients. About 30% of patients had liver metastases, and about 12 to 13% of patients had more or equal than 3 lines of prior treatment. So here are the overall survival and the primary outcome results for the EV301 study. And as you can see, the overall survival favored enfortumab vedotin with a median overall survival of about 13 months compared to 9 months for the chemotherapy arm, with a hazard ratio of 0.70. In terms of the treatment effect across the subgroups, this was all pretty homogeneous. There was no kind of heterogeneity in the different subgroups at all. I don't think the male-female ones can be interpreted, given that there was a very small number of females who received EV in the EV301 study. So in terms of progression-free survival, which was their secondary endpoint, again, this favored EV with a median progression-free survival of about 5.5 months compared to about 3.5 months for chemotherapy. And the hazard ratio there was significant as well at 0.62. In terms of tumor responses, so patients on EV had an overall response rate of about 40%, compared to 18% with chemotherapy. The disease control rate is, I think, quite impressive at 72%, compared to 50% for chemotherapy. In terms of treatment-related AEs, these differed between EV and chemotherapy. There was certainly less myelosuppression for patients on EV compared to chemotherapy, but there was certainly more peripheral neuropathy and maculopapular rash, which we'll go into later. I highlighted this red box because I think sometimes we get so focused on peripheral neuropathy and rash with EV that we forget that patients can get a lot of reduced appetite, fatigue, and dysgeusia, and those are very common side effects of EV. In fact, when you look at the quality of life data, which I haven't included here, the only quality of life I guess symptom that was decreased for EV compared to chemotherapy was actually reduced appetite. So EV actually caused more detriment in quality of life and reduced appetite in the symptom scores compared to chemotherapy. In terms of treatment-related AEs, most of them were successfully managed with dose reductions or treatment interruptions, and a very low proportion of patients required withdrawal of treatment. And the most common reason for leading to dose reduction and dose interruption, as well as dose withdrawal, was peripheral neuropathy. The AEs of special interest generally occurred early in the first few months of initiating treatment, and that is particularly true of skin reactions and things like dry eyes and hyperglycemia, surprisingly, but peripheral neuropathy occurred at approximately 3 months. So I'm just going to highlight a case and hopefully generate some discussion. So this is a 78-year-old man who lives with his family. He initially presented with an ECOG performance status of 1, but as I'll talk about, after his first and second line treatment, he became an ECOG performance status of 2. His comorbidities included type 2 diabetes with an HbA1c of 8.1%, and with some grade 1 peripheral neuropathy. He has hypertension and hypercholesterolemia. And he essentially was diagnosed with metastatic upper tract urothelial cancer with bone-only metastases. He initially had stable disease on cisplatin and gemcitabine, although his peripheral neuropathy became a little bit worse, but it was just borderline grade 2 at the time. And he progressed on maintenance of avelumab after 15 months. So he initially had a pretty good response to maintenance of avelumab. I do genomic profiling in pretty much all my patients with metastatic urothelial cancer, and he had no actionable genomic alterations. So these are his bone metastases after chemotherapy and avelumab. So when I saw him at that point, he was quite unwell. He had grade 2 pain, grade 2 cancer-related fatigue, grade 2 anorexia. He was struggling even to come to clinic. His peripheral neuropathy, as I mentioned, was impinging on grade 2, and he had all those other comorbidities, including type 2 diabetes.